much for joining us today.
Thank you very much for having me. I'm really very delighted and honored to be here.
We're thrilled to have you today. So thank you so much for accepting our invitation. But can you just take the time, just a few minutes, to talk a little bit about your background and the work you do with MDCAN?
Okay, thank you very much for that question. As you said in your comments, as you just pointed out, I'm basically a doctor and a surgeon. So I think there are basically three aspects of me, okay? There's the surgeon, who is a doctor, and that defines my work at the Jos University Teaching Hospital, especially as pertains to the care of trauma patients. That's actually my area of specialty and interest. I also happen to be a lecturer with the University of Jos, and in that capacity, I'm responsible for the trauma components of the training of undergraduate students. At the teaching hospital, I also handle the postgraduate trauma components, of their training for resident doctors. And basically, that's what I do. That's what my life's work revolves on. The part about MDCAN and leadership, I think that one is just something I will say incidental, because it was not a primary preoccupation of mine. But I did find out that I have the ability to try to identify and analyze problems and situations around me, and to try to use resources within my means to try to achieve solutions. And I think this is probably what my colleagues recognized that made them, encourage me to seek for positions in the MDCAN. The MDCAN basically is an association of all the medical and dental consultants as specialists in Nigeria's public health sector. For the past 1.5 years or so, I have been the national president, but I didn't start from there. I had done a lot of work, in other offices for the association, both locally and at the national level. And I think that is what gave me some element of knowledge and understanding about the problems confronting consultants in particular, but healthcare in Nigeria in general, especially as relates to the work environment of consultants. So I think this is partly what encouraged my colleagues to entrust me with this position. As an association, our main objectives are to improve the welfare of our members, but we cannot do this without looking into the workspace environment within which our members and other health workers, discharge their duties. And to do this again, sometimes we have to take a critical look at the contemporary issues in the country, especially as they affect health. And during our annual conferences and workshops and NEC meetings, these are subjected to extensive deliberation, and we come up with positions that we advance to government in an advisory capacity. Of course, there are times when we are forced to confront and oppose some policies which we feel may be detrimental to overall health service delivery in the country, and in particular for the consultant. And I'm sure that you know that some of these things have a bearing on the topic that we're going to discuss today, because one of the responses that we get from health workers when this mix of workplace environments is wrong is what we're talking about today, brain drain. Thank you.
Thank you. That's actually a perfect segue into my next question. So thank you very much for that. As you rightfully
You're welcome.
mentioned, we will be talking about the brain drain. And the medical brain drain in Africa is estimated to cost the continent about $2 billion annually every year. In your opinion, why do you think so many highly skilled medical professionals are choosing to leave the continent? And what do you think can be done to curb immigration?
Well, I think that the first thing to recognize is that there are different patterns of brain drain, and it's good to be sure that we're, on the same page. Basically, you could define brain drain as the movement of highly skilled, in this instance, health manpower from one place to another. Okay. One of the peculiarities of this brain drain in our environment is the abnormal situation where it's a movement from a less well-endowed system to a more well-endowed system. You would expect the reverse, but that is not the case. Now, there are other patterns of brain drain. For instance, taking Nigeria as a case study, you would see that there does appear to be an over-concentration of health manpower in the southern parts of the country, which is more prosperous and richer compared to the northern parts, where poverty rates are much higher. Again, you would expect that, where you have more need, there should be more people, but the reverse is the case. Now, even within specific states or regions, even within areas where you think there's high manpower, there is a distortion in the distribution such that there's more concentration of health manpower in the urban areas as compared to the rural areas. Okay, and even when you come to the urban areas, there's a higher concentration of health manpower within the public sector facilities as opposed to the private sector. And even when you come to the public sector, there's a higher concentration of health manpower within purely service centers, such as federal medical centers and teaching hospitals, as opposed to universities, where the work is more of teaching work. Again, even within the same state, there's a marked concentration of health workers in federal health institutions as opposed to state or local government health institutions, whereas all of them operate basically in the same space. So when you look at these patterns, of course, what worries us as a country, is the external component of the brain drain that involves emigration out of the country. Okay, but if you look at the background I've just created, you will begin to see a pattern, and that is the fact that the primary driver of brain drain is economic. There are many secondary drivers, but the primary driver is economic. If you look at the pattern I've created within the country, within different health systems, public, private, states versus federal, the underlying cause is economic. Okay. However, there are other factors, that add, I call them toppings. There are the push factors and the pull factors. The push factors are within the local environment, okay? And this has to do with like what I was speaking about earlier on, when you have a workplace environment that does not support, is not supportive enough of the dreams and aspirations of the worker, then you have them, wanting to leave. Sometimes there are inadequate equipment, inadequate infrastructure, health infrastructure, to work with. So there are many of these push factors, even within the health sector. Of course, many of the factors are also external to the health sector. For instance, things to do with the overall economy. I mean, you may be paid so much, but what use actually is that to you? There are things to do with social amenities, power infrastructure, presently in Nigeria today, security or the lack of that, insecurity, so there are many of these are push factors. Okay, another very important, extremely important push factor is the fact that many health systems do not have the capacity to absorb the health manpower being produced by the educational and training institutions. Nigeria, for instance, does not have the health system infrastructure that can employ or absorb all the doctors that are produced in Nigeria, that can absorb all the nurses that are produced in Nigeria, that can absorb all the pharmacists, and so on and so forth. Okay, and therefore you have a system whereby the country has distorted health indices. You have a ratio of about one doctor to over 2,700 patients, as opposed to 1 to 600, and yet there's unemployment in the health sector. Okay, a lot of the times when we train young people, they are forced to emigrate simply because they are not able to get a job. Okay, so this is another very major, push factor. Of course, when it comes to the pull factor, this has to do with the work environments in destination countries. Again, like I said, the primary motivator is economic, and therefore you find that they're actually paid over and above what they would ordinarily earn in their home countries. But in addition to that, there are other perks or incentives, such as a functioning health system that is supportive of their careers, their need for training and retraining, their dreams of sub-specializing or super-specializing, as the case may be, that offers them some health benefits they are not able to enjoy. Okay, I've had a colleague, a very, very senior, fantastic nephrologist, that's a colleague and a friend here. And one of the factors that made him emigrate was the fact that he observed that if he himself were to require the kind of services he renders to his own patients, he will not be able to get that kind of treatment within here in Nigeria. And if he would, he could not possibly afford it himself. Okay, so these are some of the conditions in the receptive countries, that makes it possible for this phenomenon of brain drain to take place. Now, I don't want to go on and on. The second part of the question is what we can do about this. I think the important thing is to recognize that brain drain has consequences beyond the health sector. Brain drain has consequences that permeates every aspect of the society and the economy. First of all, our education model in this country is such that it is rendered as a semi-social welfare scheme. By that, I mean that, the government invests in the education, especially of health personnel. The school fees we pay as medical students or residents is not enough to produce the finished product. Okay, so that is why it's said that between 2010 and now, a country like Nigeria would have spent about $2 billion, training this manpower who are now left to emigrate. And so when you do that, you find out that, it's an investment you do not benefit from. Okay, you've sunk in money ostensibly to achieve an aim, but you've not put yourself in a position where you'll be able to benefit from the investment you have made. Okay, and then also you have the ripple effect. Of course, the more people leave, the worse our health indices get. The greater the maternal mortality, child mortality, infant mortality, the life expectancy, the doctor-patient ratio, nurse-patient ratio, all those things deteriorate. And when they do, it means that, even when people seek health, okay, you go to a hospital, the work that's been done by 5 people is now being done by 3 people or 2. And that means that the amount of time you spend in the hospital increases, and that is loss of man hours. Again, if you have a more sick population, then you have a lesser amount of the population to rely on to drive other economic activities. Of course, even if you derive, today we want to, join the rest of the world in immunizing for COVID and all that, that is laudable. But can you imagine if you do not have the health personnel to drive that program? Of course, you will have a problem. So I think the first thing is to recognize that this brain drain phenomenon has impact beyond the health sector and permeates every aspect of the society. I think the best way of approaching it is to make commitments as to regarding health sector funding. Okay, there must be a commitment, all right, to increase the amount of money that is allocated and expended on health. There must be a commitment to get people to commit to their own health. Okay, and by that I mean people have to buy in to the idea of universal and mandatory health insurance for everybody, you know, however basic the package is. But people need to have that sense of ownership and responsibility. This is what we are contributing. Of course, a country like Nigeria has set up a process to pool funds from the private sector to be able to get funding, something in the concept of the TED fund, but for tertiary health institutions. I think that is laudable, you know. But I also think that there's a need to make a conscious effort to engage the private sector. Okay, because number one, the public sector is not able to absorb all the health manpower produced per annum, and the public sector also has a lot of inherent inefficiencies that are absent in the private sector. And so there's a need for government to make a conscious effort to invest more or make it possible for the private sector to engage more in the business of health service delivery, even if it means public-private partnerships, such that the private sector efficiency will be brought in to match the assets, you know, that are already in existence in the public sector. I think if this is done well, we might begin to reverse this trend. Thank you.
Thank you very much for that very insightful comment. So from what I gather from what you said, you talked a bit about political will, how that's very, very important, right? In getting more funding, you know, increasing, you know, strategic public-private partnerships, you know, actually pushing forth and ensuring that universal healthcare does happen so that everyone has access to quality healthcare services. So that is a great point, and it's something for us all to note. I will move on to the next question. So I recently read a very interesting article on how technology may be one of the solutions to address the brain drain in Africa. What are your thoughts on this? And from your perspective, how can technology address some of the human resource challenges in the medical sector?
Well, I think that there is no doubt that technology has a very major and prominent role to play in the health sector. I think that there's no doubt that technology can go to some extent. It is not a panacea, but it can go to some extent to mitigate and ameliorate some of the imbalances imposed by deteriorating health worker versus population ratios. Okay, but the flip side of the coin is that, you know, for technology to be able to play that role, there needs to be that conscious effort to modernize the health sector. By modernize, I mean to digitize it further, increase deployment of information and communication technology, increased automation. Okay, one of the problems that we have with our educational system is, you know, producing end products that have a mismatch with the market demands, with what the society, the employers really need. Okay, these days there are equipments, especially laboratory equipment, that, you know, are so automated they can run, you know, samples that used to be done by 4 or 5 people in one day. It can deliver that to you in 1 hour. So what I'm saying is that if we were to automate, you know, and deploy more modern technology in certain aspects of our operations, definitely that will ease up some of the problems. Another area I'm particularly concerned about is, you know, the role of technology or its absence in record keeping. Okay, electronic, especially the absence of electronic medical records in majority of places. Of course, I consider that, you know, quite a number of places have deployed this tool, and it's amazing the amount of cost savings, in terms of man hours and time. that can be achieved by, deploying this simple tool, because sometimes patients come to hospital and spend hours while their files are being manually sought for and all that. So I think this is an area in which technology can come in. Another aspect is in the idea of telemedicine, okay, especially if it is conducted within the same geographical area. I say this because telemedicine, again, is not a panacea, and there are medical and legal issues relating to jurisdiction, license to practice, ethics, and other such considerations. Of course, we know that it is possible to stay in Abuja and consult a patient in Lagos or Atlanta, for that matter, or anywhere in the world. Okay, but with that comes issues to do with licensing. Are you really authorized to practice the prescription you're about to make? Do you have the legal authority, to do that? Okay, so there's a limit. There's a limit to which technology on its own will reverse the brain drain, because it's not likely to replace. It's not likely to replace the health manpower that are immigrating. However, it can increase the efficiency of the workplace drastically, such as to free up resources for investments in other areas, that need input. Another critical aspect of technology is that it is basically power driven. From information available to us, to me as consultants from different parts of the country, many of our institutions expend up to 50% of their internally generated income on diesels to power their generators for power supply. Okay, and so if that ties up funds that could have easily been made available to other areas, such as equipment, modernizing equipment, and training and retraining of staff. Again, some of these platforms, require internet and connectivity, and you will agree with me, this is something that is not yet cheap in these parts of the world. So again, it comes back to the idea of trying to find a solution towards healthcare funding, and to be able to mobilize and deploy enough resources to be able to fund some of these infrastructure. But there is no doubt in my mind that technology can, to a great extent, mitigate some of the problems we face from brain drain.
Thank you for that. And I just wanted to add that, we've seen in several places, even here in Nigeria, where you have, doctors that are consulting from the diaspora, for example, and are partnering with their colleagues that are here, that are on the continent. So as you said, to kind of mitigate the gap in services that are here now. And I wanted to know, you touched a bit on that, but I wanted to know what your thoughts are on that, and how do we encourage that more?
I think that there is no doubt that the potentials are there. There is no doubt also that the capability is there. The technology does exist to permit those online consultations. What is, for instance, I'll give an example. It's possible to perform surgeries robotically, and the surgeon does not even have to be in the room. Okay, so it's possible for somebody on one continent to perform an operative procedure on a patient in another continent. It is entirely, the technology exists, like I said, but there are some fine points that need to be addressed. That's like crossing the T's and dotting the I's. Okay, I think that the aspect of regulation, has to come in. We have to, medicine is a very conservative field of endeavor, okay, where because of the fact that life is involved, we're not too quick to deploy new ideas or concepts, especially where the safety aspects have not been fully ironed out. Yes, I agree it is possible to have those consultations across continents, but I favor more conversations and consultations between colleagues. Okay, because there is that element of being there and knowing what is on ground. In medicine, for instance, we say that common things are common. Okay, if a patient in Atlanta tells me they have fever, the first thing that will come to my mind will not be malaria. Okay, so that's the kind of things I'm talking about. So when these conversations take place between colleagues, okay, it is possible that ideas can be shared, ideas can be cross-fertilized in such a way that resources are shared. But I think that other aspects still need to be ironed out. Like I said, information about a patient is something that is very, very highly confidential. There are ethical aspects. If you're going to relay a patient's information, pictures, clinical photographs across an online platform, the security of which you have not laid down guidelines for minimum standards, and then exposing the patient to possibilities of their information, getting out of where it's not supposed to be, then those are causes for concern. I've also interacted with a number of colleagues in the diaspora, and one of the concerns they raised is the legal framework. Okay, in order for you to be able to make a prescription, for instance, you need to have a license to issue that prescription. So, but I think these are issues that can be easily, sorted out. But no doubt, especially between colleagues, I think is a wonderful thing that is going to, take us places in the future.
Thank you very much for that. So, Professor Ozoilo, it's almost like you've answered my next question, but I will still ask it anyway. From the lens of leadership, how important is leadership and political will in addressing the brain drain in Nigeria and across Africa? So you've touched a bit on that, about funding, about public-private partnerships, but is there any other any other way that we could also look at this? And what are your thoughts?
I think the whole problem with brain drain, especially for countries like Nigeria and Sub-Saharan Africa, I think it all boils down to leadership. Okay, and the flip side of the coin is also true. The ability of the destination countries to attract and retain these brains that we're losing also boils down to leadership. So I think everything revolves around leadership. A country needs to be able to make some decisions and commitments based on a thoughtful, careful, objective, and dispassionate analysis of problems on ground. Okay, so where this is lacking, then you have some of the kind of dysfunctions that we have. I give you an instance. Even issues to do with employment. Okay, officially in Nigeria, at least, most public health institutions have an embargo on employment. Okay, why? Because the decision makers have not recognized that the funds you're trying to conserve, there's a relationship between your health system and your economy, for instance. Okay, and so it's very important that we'll be able to make some of these hard decisions. There was a commitment for countries to deploy at least 15% of their national budgets to health. Interestingly, that conference held in Abuja, and it's also referred to as the Abuja Declaration, and since that declaration was done, Nigeria, the host, has never really gone beyond 9%. It has never come anywhere near that 15%, and so this is all a matter of leadership, because it's leadership that determines how resources are allocated. And I also believe that leadership also determines to what extent some some factors in society, external to health, but that also influence health, play, interplay in this issue. For instance, I've spoken about embargoes on employment. In some places, even in federal institutions, you cannot get a job without some form of connection. I mean, this is a total failure of leadership. In some places, the skill that you bring to the table is of secondary importance to the links that you have to politicians and people in the corridors of power. And so what this does is that it demotivates. It kind of kills the faith of the individual in the ability of the system to be there for everybody. Again, this is purely leadership, okay? And then the sincerity of policymakers, of decision makers, you will find out that oftentimes when programs are being deployed, the driving force, the primary thing may not necessarily be the impact, but the interests of the decision makers involved in the process of taking that decision. I mean, I'll give you an example. I was discussing with the top government officials, and he was trying to justify citing a particular institution in his hometown, and his justification was, well, I have to give my people something also. It's on the surface, it seemed to be on the lighter side, but I thought that was truly unfortunate, because such decisions, need to be made based absolutely on impact. It is absolutely no use to have a facility in a place where you have neither the resources, nor the manpower, nor even the patient load to optimally make use of that facilities. So all this boils down to leadership, okay? And one other aspect of leadership that I want to harp on is the aspect on transparency and sincerity in governance, okay? Nigeria and a lot of sub-Saharan African countries are plagued by corruption, okay? The corruption is manifest in every facet of life, okay? And even though it seems hidden, but the ordinary individual, the average individual can perceive it. And he perceives it each time he has a contact with agents of state, okay? And so that's what that does, is to create that feeling of oppression and suppression that gives you the feeling that, look, I cannot get an equal chance, I cannot get good opportunities in this environment, and therefore I must leave. Again, these things are very evident even to young people, and I think that's where leadership starts. By the time people get old enough to be in power and all that, you could argue that their mind is set. But there needs to be a deliberate effort to teach leadership, things to do with mentorship, and teach, because I believe leadership is a doing word. It's not a talking word. You cannot say one thing and do the other and call that leadership. It's not. The fact that you're being objective, you're being dispassionate, and what you're doing is making sense and is tied to, proposed solutions are tied to observe problems. To me, that is how to teach leadership, and we can teach this to even young people, such that in whatever sphere of influence they are, and this is the discussion I have with my younger colleagues, where I work and teach, the fact that there is an opportunity for leadership at every level, however narrow your sphere of influence is. The truth is that there are some things that are your responsibility, and so if you are able to, exercise that leadership, and how do you exercise it? Number one is to be there. You look at the problems, you think up a solution, and you look at resources that are available and try to match them to the problems on ground. To me, that's what leadership is all about. But when you look at many of African countries, this truly is what is lacking.
Thank you so much for that. That was very, very interesting. And I really want to just touch a bit on this leadership bit. So what you said is something very much kind of like the ethos of the HLA. And we really believe that everybody is a leader, in your respective sphere of influence, whatever you're doing, you can be a leader. And it's to manage your resources, like you said. And another key component is to take ownership. So if you own whatever you're doing and whatever role that you are doing, and you make sure that you do it to the best of your ability, you are in fact exemplifying some bit of leadership. So thank you so much for that.
Thank
And
you
let
very
me
much.
and to my next question. So while many African countries are not known for medical tourism, there are a few, including South Africa. What do you think are the steps that other sub-Saharan African countries need to put in place in order to make their countries attractive to medical tourists and more so to strengthen their healthcare systems?
Okay, thank you very much for that again. I think we had touched on a little bit of this a bit earlier on, because for me, I like to, examine problems in an analytical way and trying to find out the ramifications. Now, if you look at medical tourism, okay, there are reports that in the year 2018, Nigerians spent $1 billion on medical tourism in that single year alone. At the exchange rate for that year, that $1 billion was equivalent of over 350 billion naira. That was nearly the entire health budget for that year in Nigeria. So the funny thing is, who would believe that that amount of resources was actually existing within the system? But it is. For that amount to be spent, to have been spent outside on health, meant that if the facilities had been there in country, it would have been far cheaper and it would have been far more logical to access these services in country. Okay. It also means that if the country were to invest, for instance, in these areas, the patient load is there already. The customers, well, sorry to use a business terminology, but the uptakers, the people that are going to take up the services, they're already there and just looking for who will provide the services. Okay, and this is where the interplay between the government and the private sector comes in. I believe that if we're going to reverse medical tourism, a lot of the efforts will have to come from a greater engagement of the private sector. Why? Because I mean, these are organizations and individuals, whose primary business is investing. Okay, but we have this there's this mismatch where government tries to do everything. Of course, it's not able to, and fails to put in place what needs to bring in the private sector to complement what it's doing. I've already said it's not possible for the public sector to employ everybody. It's not possible. Okay, but I also don't believe that creating employment is all about issuing employment letters. I don't think that is creating employment. But if you were to make it possible for people with investable funds to invest these funds in your health system, okay, that amount of capital flight will be contained in country. Okay, of course, the effect on the economy, that one, I don't want to go into that. I just want to restrict myself to the health component. Okay, but how do you then engage the private sector? Okay, there are some basic things that you have to put in place. Okay, I've talked about infrastructure, power. Okay, the power, a solution has to be found for power, because a situation where you're spending 50% of your internally generated income just to power diesel plants and all that is not a sustainable system. Okay, and then other incentives also need to be put in place. For instance, it doesn't make sense that you're complaining about health indices and yet you place maximum tariffs on importation of medical equipment that would drive this modernization and advancement of the health sector. You'll be surprised to learn that even some government facilities import equipment and this equipment rots away in the ports. Why? Because they're not able to clear the same equipment from the customs. You understand? So it really doesn't, there's a disconnect there. But I believe that the role of government has more to do with policies, to put in place policies that will encourage investors to bring in these funds, knowing fully well that the patients who need these services are there, and the patients who have the capacity to uptake, the capacity to pay for these services are already there. And I think that, government would do well to, not just Nigeria, but, other African countries, to work in this regard. Recently, during the period of the COVID-19 pandemic, there was 100 billion naira or something. I can't remember the exact figure. That was set aside by the CBN as part of, for the health sector. I'm not aware of anybody who has been able to access that fund. It just doesn't make sense. It has to be an active process from policymakers to engage these private sectors, find out where the areas of concession that they seek, and then grant this so that we'll begin to reverse this kind of situation. Another interesting thing you may not know is the fact that the medical schools in the countries are not enough. I'm talking about Nigeria now. Do not produce enough manpower to replace the people that are leaving the country. Okay. Meanwhile, the quality of the products, there's no argument about that. But what is happening now is we're having a lot of medical graduates, foreign trained medical graduates coming into the country. Okay. And this represents another sort of medical tourism, because these are people, they are smart enough, to read medicine, but they don't have the chance to read medicine in Nigeria. They have the money to pay for reading medicine. They do not have the opportunity to even pay with their own money. So what do? They go to schools outside the country, mostly Eastern Europe, Ukraine, Egypt, Sudan. Okay, and they get their medical education and they come back. What am I saying? In the interim, so much money has been spent educating those people outside, using patients with disease patterns that are not the same as ours. Can you imagine what will happen if you were to set up these institutions, okay, in country to uptake all these people that are able, they're qualified to read and they're able to read and they have the capacity to pay for this education? We will retain that back in country too, okay? But like I said, there has to be a conscious effort from the government and a very, very strong and strategic public-private relationship to make it happen.
Thank you. Thank you. So because we're almost running out of time, I want to start taking questions from our audience. Okay. And the first question we have is from Dr. Elizabeth. Her question and comment says this: there is no doubt that local push factors and external pull factors influence medical brain drain. And until a nation addresses its local push factors, medical brain drain will remain a fixture in the country. Surely medical brain drain cannot be all bad. My question is, are there any advantages to medical brain drain? And if there are, there must be ways in which local medical professional bodies can harness these advantages to improve healthcare delivery. How can medical brain drain be turned into a positive for countries affected by it? Thank you for that question.
Okay, thank you very much. I agree totally with Dr. Elizabeth about the push and pull factors. Of course, everything that has a disadvantage might have an advantage, okay? But I think that in this particular situation, it's we'll have to look at the overall balance, okay? We'll have to look at the overall balance, and I think that it's entirely it's more tilted towards the negative, okay? Of course, the CBN keeps talking about diaspora remittances, and you would think that, okay, when people go and earn better, they send their remit money home, which feeds into the economy and all that. But if you compare and contrast, the pluses and the minuses, I do not think that overall, because look, you could have the money, but like we said with medical tourism, it simply is nobody to access that money no hospital or institution that is able to access that money for it to be useful to you for the purpose of your health. So I think that a lot more still has to be done. Okay, and then of course there are relationships, between local doctors and colleagues in diaspora, especially those of Nigerian origin, like the ANPA, Association of Nigerian Physicians in Americas, and stuff like that. Of course, this idea of giving back to home is something that you could, tap into and develop. But again, that is something that has to be well thought out and channeled in a way such that it's helping to build the system. Okay, there's no doubt that those relationships help, but honestly, I think on the balance of the skills, I think it's hugely disadvantageous. Thank you.
Thank you for that. So we have several questions and comments here, and I thank you all for typing in your questions and comments. Please keep them coming. But I want to stick with the ones for now that are related to the topic. So we have a question here that says, or a comment, how can our leaders be made more aware of their critical role and held accountable in this regard, as it regards to, I guess, the medical brain drain?
Well, for me, I believe in continuous engagement. There is no alternative to that. We have to continuously engage them using different platforms. And I mean, these people, they do not drop from the sky. They're part of us. They are from within, and invariably, one way or the other, somebody is able to reach out to them. For me, I think that one of the responsibilities we have, is to be participatory, and this is one reason why I got involved in MDCAN so much, because I found out that there's a limit to what I can do inside my operating theater. There's a very, very huge limit to what I can do, because the decisions that affect what I can do are taken from way above me. And I felt that it's better for me to engage. And I found out when I engage with the decision makers, I may not always be able to get them to do what I want, but I understand where their challenges are, and they understand where my challenges are. And somewhere down the line, we find a middle ground that permits me to be able to have some of the resources I need to discharge my duties, while also allowing them to be able to achieve a balance in their ability to spread resources across many competing priorities. So I think that one of the worst things we can do is to lay back and complain about the leaders instead of coming out and in whatever way we can engage in. If you've followed me and my association, we've not every opportunity we've had in our press conferences, in our meetings with government officials, we tell it as it is. And I think that is just a starting point. Of course, if we find ourselves in positions of authority where we're able to make decisions, of course, we already know what to do. I think that's a good starting point, if you ask me.
Thank you for that. So we have another comment / question here. I think leadership alone is not the limiting factor for the brain drain. The elders in the medical industry, when attaining leadership positions, contribute badly for younger ones to even step on the ladder. Imagine young doctors, looking for a house, I think he meant housemanship, for more than 6 months. Do you expect such doctors to practice in Nigeria when to even get placement for Nigeria is hell or very difficult?
Yes, I've alluded to this, and it's truly unfortunate, that where you don't have enough doctors, there is no employment, there's no job, because the infrastructure is simply not there. But I don't want us to engage in, blaming, blame game. You understand? I prefer constructive engagement. Yes, it may look like the senior doctors, have not done enough to help the junior doctors. I think it's an escapist way of thinking, if you ask me. I think that what works better for me is to find out why. Why is it that they are not able to do this? And most of the time, if you come close, you're going to find that the reason is not because they hate young doctors. They don't. It's not because they hate the profession. but they're not there as doctors. They are there as, politicians, and they owe their ascendancy to factors extraneous to the medical profession and the medical constituency. Okay, so if he's there and he has a party allegiance to live up to, he has influencers and people that put him where he is, the number one loyalty is to those people. Now, these are some of the things we need to begin to break by ensuring that we are more participatory, and that's why I keep talking about participatory. But then, by that I don't mean party politics alone. I mean that at every level of leadership, we should be able to be engaging, because that is how we'll be able to prop up people that will emerge and be able to ascend into positions of authority, where they emerge not by some benefactor that they'll be beholden to, but because they have something to offer and because of the quality of what they bring to the table. So this is how I would like to look at it.
Thank you very much. So we're going to wrap up, and I appreciate that last statement. So it's not about playing the blame game, but it's about how can you actually contribute and do your part in making the system better. And I think that's a very, very good note for us to leave on. Everyone can think about what they can do, at least to support the upcoming doctors, nurses, medical professionals, as they try and make our system better. So there's somewhat, as you said, a collective responsibility. So from, the politicians in office and from the government, there's also a collective responsibility from the private sector and from the healthcare workers themselves, and of course from the recipients, right? So everyone has to take ownership of making the system better. Professor Ozoilo, this was such a wonderful conversation. I thank you so much for your insights. We've learned so much. I just want to give you an opportunity. I know that you've written several publications. If anybody is interested, where can they find out more about your work and more about you?
Okay, thank you very much. I must say that I look so much forward to this opportunity, and I want to express my thanks and gratitude for, letting me have the opportunity. And I also want to thank you for the work you do. I believe that a lot of the problems that are faced by this country can and, will be solved through the kind of work that you guys at HLA do. And I really want to encourage you to, keep it up. And we hope that as time goes on, we'll be able to see more results and fruits. Yes, my work can be seen on different platforms. Most of them are online. The University of Jos repository is there. I think it's www.unijos.edu.ng. A lot of my work is also on LinkedIn, PubMed, and ResearchGate. I think if you type in my name Ozoilo KN on PubMed, most of my work, a lot of my work is there. And also, if you reach me through LinkedIn, especially, I'll be able to supply full manuscripts of the work done on request. That can be done. So thank you very much.
Thank you. Thank you once again. Thank you everyone for joining us. This was such a wonderful session. We pray that you go back, take ownership of your role and what you do, and join us for our next webinar. Thank you, everyone. Have a wonderful day, or wonderful evening, rather.
Yes, thank you very much, and have a wonderful evening yourself.
Thank you.
Thank you, everyone, for listening. Bye.
Thank you.
Yeah.